This is the case of a 66-year-old woman with no significant past medical history, who presented to the emergency department of Rio Ortega University Hospital with progressive pain and swelling in her left lower limb. The symptoms had been worsening over the previous 48 hours, interfering with mobility and causing substantial discomfort. A Doppler ultrasound performed by the radiology department revealed an extensive, acute deep vein thrombosis involving the iliofemoral venous axis on the left side. Initial management included anticoagulation with low molecular weight heparin and prescription of graduated compression stockings. The patient was discharged with close outpatient follow-up. However, within a short period, the patient returned to the emergency department with worsening edema and severe pain, unresponsive to analgesics. Given the clinical progression, a contrast-enhanced CT venography was performed. The scan demonstrated a large thrombotic burden extending from the popliteal vein distally up to the inferior vena cava proximally, confirming occlusion of the femoral, external iliac, and common iliac veins. An urgent hospital admission was indicated for symptom control and evaluation by the vascular surgery department. Given the extent of the thrombosis and the failure of conservative management, a hybrid surgical and endovascular intervention was planned. The procedure began with a surgical approach through a left inguinal incision. A femoral venous patch angioplasty was performed to restore luminal diameter, followed by the creation of an arteriovenous fistula between the saphenofemoral junction and the common femoral artery to improve venous flow dynamics. Subsequently, a diagnostic venography was performed to evaluate the morphology and extent of the thrombus. This confirmed the extensive occlusion and guided the endovascular intervention. Mechanical thrombectomy was carried out using the Penumbra Indigo flash system, a high-performance aspiration catheter designed for peripheral venous thrombosis. A 16 French 80 cm catheter with a curved burr tip was used to advance through the thrombotic segment under fluoroscopic guidance. Multiple aspiration passes were performed with slow, controlled movements to maximize clot removal and avoid venous collapse. The final venography demonstrated successful recanalization of the iliofemoral venous axis with marked reduction of thrombotic material and restored contrast flow toward the inferior vena cava. The patient's postoperative course was uneventful. She was discharged with oral anticoagulation using dabigatran, prescription of compression therapy, and a structured outpatient follow-up plan. This case illustrates the value of early endovascular intervention in selected patients with extensive proximal deep vein thrombosis, particularly when conservative measures fail.